is we just finished our conference in Vail, Colorado, where we had about 3.5 days of intense clinical pathologic lectures, both it's a lot of clinical discussion, therapeutic sessions, topics related to business, legal things, and then obviously a lot of dermatopathology in there. So that also has been recorded, and it is also available to view. There is a fee for that for residents. It's obviously significantly lowered. We actually did have about 5 or 6 residents that came to our meeting this year. I think they really had a good time there and enjoyed both being in Vail, Colorado in the summertime, as well as learning a lot. So those are some resources for you that are out there. We're going to continue to create a large library of good information for you. So today we're going to be talking about metabolic disorders. This is a talk that was scheduled, I believe, a number of months ago, but we had to push it back because it conflicted with the American Academy of Dermatology meeting, which actually was a virtual meeting this year also. And so we're going to give it today. It'll be online, and then we're going to start up with the unknown sessions later next month, and then we'll go on and do some other talks to supplement those we've already given. So first one of these, it's a shave biopsy, and you can see it shows basically minimal inflammation at low magnifications, few little lymphocytes here. You can see some melanophages, but notice that the papillary dermis is expanded. It's almost got kind of a ball and claw-like architecture with the epidermal rhescia here. And whenever you see that, you should ask yourself, why is that happening? What's in there to make that papillary dermis kind of turgid, if you will, and that the epidermis is kind of, sort of hugging around it? It means that there's something in the papillary dermis making it firmer than it normally would be. And that can be granulomatous inflammation sometimes, like in lichen nitidus, for example. We see sometimes metastases of cancers can do that. Vascular lesions can do that. And then obviously, since we're dealing with metabolic disorders, well, we think about the possibility of amyloid. And here we see these large clumps of amyloid, and this is amyloid that's derived from the keratinocytes. And you can actually see that happening right here, these little dyskeratotic keratinocytes. And then the grayish and sometimes pinkish color of the amyloid that's present in the papillary dermis, and then the epidermal rete that are kind of surrounding those little dermal papillae there. So this is macular / lichen amyloidosis. And you can see these this is kind of what you see most of the time. You see these little tiny globules of amyloid. Sometimes you see just a little teensy tiny amount that's just beginning to develop. And you very commonly get melanophages. As you know, the clinical situation where this arises is usually in patients that have relatively dark skin types, Hispanic individuals, for example, and it's often on the back or the trunk, but in the lichen amyloid is often in the pre-tibial areas. So, and that would give you these little fine papules with kind of a rippled pattern. Notice that there also are these clefts between the individual aggregations of the amyloid. That's very characteristic of this also. So that is macular amyloidosis or lichen amyloidosis. When basically it's the same process. When it's rubbed, it gives you more of a lichenoid morphology because of the lichen simplex chronicus. And this is also amyloidosis. And here we see not the pattern that's just involving the papillary dermis. We see a diffuse pattern where there's just basically everything you see here is amyloid going all the way from the epidermis down to the subcutaneous fat. And there are blood vessels, and you can see that there's amyloid in the wall of these blood vessels here. So this is nodular amyloidosis. And there are 2 types of nodular amyloidosis. There's the type that's basically a solitary papule or nodule, or sometimes even a tumor, often seen, because it can be seen anywhere in the body, but it's often seen in the head and neck area, and it can look like a basal cell carcinoma or lymphoma, something like that. And that is not associated with systemic amyloidosis or with a myeloma or any kind of plasmacytic disorder in the vast majority of the cases. If you see it, you probably owe the patient a workup just to make sure that they don't have anything going on. But usually, if it's the solitary nodule or plaque, it's not associated with systemic amyloidosis or systemic plasmacytic disorder. If you get more of the sort of diffuse plaque type that's involving the deeper blood vessels. That type very commonly is associated with myeloma and that sort of thing. So you definitely need to work those patients up. And those patients will often have some plasma cells within the amyloid. This one really, I don't know, there might be a few plasma cells here. There's not a lot, there's a few. So, who knows? This guy might have had systemic amyloidosis, but often when you see the, systemic forms, they'll have more plasma cells. You might have a cluster of plasma cells or several nodules. So those patients very commonly will have multiple myeloma or Waldenstrom's or something like that. So if you see that type of amyloid, you do need to work them up. So the nodular type, as you can see here, can involve the blood vessels, but it doesn't have to. The systemic type usually does involve blood vessels, and we often get these core needle biopsies of the subcutaneous fat that are just kind of blind biopsies to see if there's any amyloid in the blood vessels. I can tell you the yield on that is very, very low. I know the internists think it's a good test, and if it's positive, it's great. If it's negative, it sort of doesn't prove anything. And we see a lot of those come in and they just don't show it. But anyway, this is nodular amyloid, and there's two different types, again, as we just mentioned. Okay, next we're moving to a different metabolic abnormality here. And notice here we've got a punch biopsy, and it's a pretty deep punch biopsy. It goes all the way. I mean, this is probably, usually punches kind of go about this deep. Well, these guys have really taken the punch and they've buried it all the way to where the plastic white area is, or blue, whatever the color of your punch is. You got to really, they've really telescoped it into the skin, and they still haven't even gotten to the subcutaneous fat. And when you see that, you should say immediately, gosh, that skin is obviously way too thick. Any kind of time you have a punch biopsy that goes this deep, we ought to see a lot of fat here. So it's either replaced by something, or the dermis is just so thick that basically you can't get there. And whenever you see that at low magnification, the first thing that really should come to your mind is scleredema, especially when you're getting electrometabolic disorders. But scleredema is very common. And the old Fitzpatrick book, I don't know if they still have this, but when I was a resident, they had a picture there of a gross specimen that was taken at the anatomic pathology gross table, and it showed the excisional biopsy, and it was just really, really markedly thickened skin. You can even see it just without even a microscope. But this is what happens when you look under the microscope. So it's mainly just markedly thickened dermis that's way, way too thick. And you're supposed to see mucin between the collagen bundles. But I can tell you that the mucin that we see in scleredema is minimal. It's not really dramatic. The main changes are just the marked thickening of the collagen bundles. And so, there's a little bit of mucin in here, but notice that it's not the kind of mucin you see with pre-tibial myxedema. It's not the kind of mucin you see with GA. It's just kind of a slight amount of mucin between these very, very markedly thickened and increased collagen bundles. That's called scleredema. That's because the skin feels thick and sclerotic, but there's not a whole lot of real true sclerosis like we see with morphia and that sort of thing, where you get homogenization of the collagen bundles. The classic histologic diagnosis of sclerosis is homogenization of the collagen bundles with a decrease in the number of fibroblasts. Here we do have what looks like not really an increase in the number of fibroblasts, but we have mostly thickened collagen bundles, and they're not really homogenized and sclerotic to the same degree that we see in morphia. So it's a little bit different. You can see that these are thickened collagen bundles. They're kind of, there's clefts between them, and there's mucin here, and it's markedly thickened. Here's an eccrine sweat coil, and it's, kind of looking like it's in the lower part of this thing, and it's got a lot of collagen beneath it. That's absolutely abnormal. So again, this is associated with diabetes in some cases, not always, but basically just think of scleredema when you see something that's markedly thickened like that. Now, there are some other things, the differential diagnosis of scleredema. You can get collagenoma and, elastic tissue nevi, things of that nature. They can look a little bit like that. Elastofibroma dorsi, which is a type of elastic tissue tumor of the back, if you will. But again, those don't give you this markedly thickened dermis. And if you did an elastic tissue stain here, it actually wouldn't really be positive. This is mostly collagen here that may have even replaced the elastic fibers in many areas. So you'd see some elastin would be kind of normal background elastic, but it wouldn't really be an elastic tissue abnormality here. So that's scleredema. All right, the next one we're going to look at low magnification here, you can see that the dermis looks pale. And whenever it's pale like that, you say, well, why? Is it because of edema? Is maybe there's mucin there, something along those lines? And in this case, it's massive deposition of mucin. Okay, so the last case of scleredema, we saw a little bit of mucin between those thick collagen metals. Here we've got everything is mucin. So all this stuff here is mucin. These are fibroblasts, they're mast cells in here. It goes all the way to the upper part of the reticular dermis, not really involving the papillary dermis here. We really can't tell what part of the body we're on, but if you look carefully, maybe there's some stasis alteration of some of these blood vessels. So this might be in the lower leg. So if we see massive deposits of mucin on the lower part of the body, the leg, we obviously think of pre-tibial myxedema. And that's actually what this is. And basically all pre-tibial myxedema is, it's just focal cutaneous mucinosis over a broad front involving the area where pre-tibial myxedema is supposed to occur, the area of the pre-tibial area of the skin. So this, you see the mucin goes all the way down to the base of the reticular dermis. It doesn't really involve the fat. So this is mucin in the dermis. And basically we know the pathophysiology is it's the long-acting thyroid stimulating antibody is basically causing these fibroblasts to produce massive amounts of hyaluronic acid. So it's not really circulating mucin that deposits there. It's produced locally within the skin, and it's analogous to the material that gets produced behind the eye in exophthalmos. There's now a new biologic agent that's actually used for that. I'm not sure if anybody has evaluated how it works for pre-tibial myxedema, but perhaps it has some efficacy in that as well. Anyway, that's pre-tibial myxedema. And the difference in diagnosis of this, if you just had a small biopsy, would be other forms of cutaneous mucin deposition, massive mucin deposition that you can see with lupus, for example, solitary cutaneous myxoma. That could look like this. The mucin you can see in a so-called digital mucus cyst, those all are basically hyaluronic acid that gets deposited. They can all look similar, but if you have a punch biopsy that shows this diffuse deposition over the entire dermis, it's much more likely to be pre-tibial myxedema. Okay. This little different animal here. Rotate it for you here, and we got two specimens. We've got one that looks like it was taken by punch technique, or yeah, probably a punch. A shave. So we might have actually had the old shave punch, which sometimes dermatologists do something like that. They do a shave and they say, oh my goodness, there's something deep. And then they go back and say, now let's take a punch because maybe there's like something more serious in the bottom of the lesion. So that's probably what happened here. And I'll look at the shave specimen first. And once again, you see a diffuse infiltrate of these pale staining cells. And as we've talked about many, many times, anytime you see things that are pale, you start asking yourself, well, why? Is it possibly mucin? Is it lipid? Is it some kind of clear cell lesion itself, like a Paget cell or cell that's like got glycogen in it? And so let's go to higher magnification. And notice that the process is confined to the dermis, spares the epidermis. And we go to higher magnification, we see that all these cells have foamy cytoplasm. So small, tiny little vacuoles and bubbles in here. And when you see that, it really favors the possibility of this being lipid, like you might see with a xanthoma. And this is a type of xanthoma. I'm not going to go through all the various subtypes of xanthomas, but I would say that I would recommend strongly that you spend a little time learning about those, the difference between tuberous xanthomas, tendinous xanthomas, planar xanthomas. In this case, we probably just call this a xanthoma not otherwise specified, but there's one thing that we would probably want to exclude on the morphology, just looking at it, and we could exclude, would be an eruptive xanthoma. Eruptive xanthomas generally they don't give you this dense nodular infiltrated these cells with fibroplasia, like you can see in the background. That's kind of a sign of a more chronic developing xanthoma that develops over the course of time. Eruptive xanthomas happen quickly over the course, really, literally, sometimes of just minutes. They can develop very, very rapidly in patients that have markedly elevated triglyceride levels. And because they develop rapidly, you can often get these lipid-laden cells that rupture, and you get extracellular lipid that can look like mucin, that can simulate granulum annulare. So eruptive xanthoma and GA can actually look similar to one another. This doesn't look anything like GA. It looks like a diffuse nodular infiltrate. It, if anything, might even look more like, say, xanthogranuloma or something along those lines, but there's no two-ton giant cells or eosinophils or anything like that. So I don't know if this is a tuberous xanthoma or tendinous xanthoma that was the surface of. I'm not sure. Now, these are not all, they're artifactual in a way, but they actually go along with this lesion. And these are cholesterol clefts. Okay, so at one point, there was extracellular cholesterol here. When we processed it in the laboratory with the xylene wash and that sort of thing, it gets washed out of the tissue and it leaves you these little clefts. So these are not all just fake, fractures in the lesion. These are actually places where there was extracellular cholesterol. So this goes along also with the diagnosis of a xanthoma. So again, I recommend spending a little time learning about the metabolic pathways of those entities. Now, this is another interesting lesion that is not really and truly a metabolic disorder, but we're going to include it in here because it's in the same family of xanthomas. And you look at low magnification, you see this verrucous epithelial hyperplasia. This may have come from an area like, say, the axilla or the genital area. It's a common location for these, sometimes the oral mucosa. It looks like a wart at low magnification. But you go to higher magnification, you see that it's got this parakeratosis up here. It doesn't have any corticolytic chain, so parakeratosis is very common with these lesions. And then we look between the epidermal rhescia here, and you see these xanthoma cells once again. And this is a so-called Verruciform xanthoma. And we think what's going on here is it's probably not really and truly a xanthoma itself. It's probably some kind of a reactive process, maybe related to trauma or something like that. And then these xanthoma cells, there are macrophages that come in and start engulfing things. And there's probably lipid-laden lysosomes in here that it makes it look like a xanthoma. But in reality, it's probably a reactive process in some way that acquires these xanthoma cells. And this is commonly where they're located. So this is a so-called Verruciform xanthoma. I would recommend knowing this entity also. This would be a fair lesion for the board examination. If I were writing the board, I might actually put this on there. So I think it's an interesting lesion, and clinically they look like these warty, reddish, friable papules, and they're usually present in one of those locations that I just mentioned. It's not uncommon for you to see some neutrophils in here and this parakeratosis and crusting kind of morphology, because clinically they do look a little bit crusted and friable. So that kind of goes along with the morphology that you're seeing clinically. So it looks like a wart. If you see a wart that looks inflamed or irritated, then always look between the epidermal rhescia and see if there's any xanthoma cells in there. Okay, we talked a minute ago about eruptive xanthoma. So if you look at this at low magnification, it almost looks kind of like a palisaded granulomatous dermatitis. So at low magnification, I would want your mind to be thinking, hey, maybe this is GA, maybe it's something like that. And then we go to higher magnification, and we notice that even though the cells look like they're kind of splayed between them on collagen bundles, and there's this grayish material, bluish gray material that's in the stroma, which looks a lot like mucin. I would want your differential diagnosis. I'd want you to miss this. I would want you to think of GA here. So sometimes we want us to make an error and say, because we know that that's in the differential diagnosis, so that GA is the wrong answer here, but it's the right pattern. Another thing that can give you this pattern again would be things like, for example, Kaposi sarcoma can sometimes give you kind of an interstitial pseudopalisaded appearance. You can also see epithelioid sarcoma. So I want you to know and think about those entities. I don't want a long laundry list of every possible, thing that can give you histiocytes in the dermis. I want you to be more specific and say, well, this one's kind of got almost a pseudo-palisaded pattern, and know that whenever you see that, and then you start looking and say, hey, these are foamy histiocytes. They're not really regular epithelioid histiocytes or obvious, macrophages that don't have any lipid in their cytoplasm like we see with GA. So this is an eruptive xanthoma. This is what lesions of eruptive xanthoma, and they can simulate granulomedullary. So that's it's an important thing to remember, is that it can histologically simulate that, but it's not GA. And if you start looking here, you can see these nice lipid-laden histiocytes here. This is extracellular lipid. These things, I would just think of them as they get so chock full, or they're saturated with mostly triglyceride, and they just can't hold anymore, and poof, they break open like a balloon, and then this stuff gets extracellular, as you see. Now, I don't know if that's exactly the pathophysiology of that, but that's one way to think about it. And got a few little cholesterol clefts here, but most of these patients have markedly elevated triglycerides, and they don't have a lot of cholesterol. So your other kind of xanthomas can get a lot more cholesterol clefts than you see in an eruptive xanthoma, because it's mostly triglycerides. And these are usually patients that have some, usually diabetics that are in ketoacidosis, and they can have lipids of 5,000 triglycerides. And these things literally can develop. We talk about eruptive, they can come up in a matter of moments. And when you lower their triglyceride levels with, you give them insulin or whatever to get those triglyceride levels down pretty quickly, they actually can go away almost as you're watching the patient. They can disappear right before your eyes. So it's kind of a dramatic thing, and it kind of shows you, when we look at a slide, we say, oh, this must have taken a long time to develop, but actually in vivo, these things, happen relatively quickly. So it's an interesting phenomenon. But just remember that it looks like GA because it gives you a pseudo-palisaded appearance, but the cells have abundant foamy morphology, and you get the extracellular lipid that can simulate mucin. Okay, our next entity obviously looks quite a bit different than what we saw before. This of the two is probably more interesting. So now we've got low magnification, a superficial perivascular dermatitis with this epidermis that's hyperplastic. And I hope you can recognize, even at low magnification, that there's abnormality primarily in the upper part of the epidermis. So there's psoriasiform hyperplasia. Notice there's this pallor, and notice where it's located. It's right at the top. This is classic for this entity, or this family of entities. So this is ballooning degeneration. Remember, we talked about that before, where you get fluid that collects inside the keratinocytes. There's really minimal spongiosis here. There's some, but the main change here is this ballooning degeneration with this overlying parakeratosis. That's also important. And notice that it's present in a diffuse pattern. It's not alternating ortho and parakeratosis like we see with PRP. It doesn't have any neutrophilic infiltrate in there. It's really pretty much this sort of broad zone of parakeratosis overlying this ballooned epidermis. Then the ballooning is present at the very top of the epidermis. This is almost pathognomonic for the nutritional deficiency disorders: pellagra, acrodermatitis neuropathica, zinc deficiency, essential amino acid deficiency, biotin deficiency. All those deficiency diseases can look like this. So the sort of end common pathway, if you will, these patients do not have enough nutritional components for their epidermis to mature normally. So instead of forming a normal basket weave cornified layer or compact cornified layer, you got this ballooning degeneration, this overlying parakeratosis, and that goes along with the crusting, the flaky paint morphology that we see with patients that have these diseases. They all histologically look similar, especially when you get them in an acute stage like this. So you biopsy an infant that's got acrodermatitis neuropathica, or you biopsy somebody from Africa that's got pellagra, they all look the same under the microscope. So basically they have the same common pathway. Now, one thing that happens when it's been present for a longer period of time. So if you get somebody that's got this, and maybe they've lived through the acute phase of it, and maybe maybe they're getting a little bit of zinc, or maybe they're getting a little bit of biotin, and they're kind of smoldering along. It begins to develop more of a psoriasiform dermatitis, and the other half of the biopsy is a more chronic form of it. And you see here, it can kind of almost simulate psoriasis. So if you see it in a later stage, it kind of look a little bit more like psoriasis. You don't see the extensive amount of the ballooning, and there's still a little bit of it left here, as you see like over in more of the acute area. So when you get one of these deficiency diseases more chronic, it can sometimes simulate psoriasis. It doesn't give you the nice mounds of perikeratosis with neutrophils and that sort of thing, but it can look more like psoriasis or psoriasiform dermatitis when it's more chronic. And if you see necrolytic acral erythema, those patients have hepatitis and they kind of get a mild or a mild nutritional deficiency. They don't get the acute zinc deficiency like an infant has. Those look more like the psoriasiform with less of the ballooning as opposed to this pattern. So just realize there's a spectrum of this, just like with everything else in dermatopathology. Okay, this is a different situation. So here we've got basically in the dermis, an abnormality where we've got all this, a lot of hemorrhage in here, but we've also got this pink purple material. And when you see purplish color in the skin like this, you should all immediately think of calcium that's deposited. And so this is an example of calcinosis cutis. Again, calcinosis cutis can be seen in a lot of different settings. We're just using it here as an example, but you can see dystrophic calcification. You can see scrotal calcinosis. You can see dermatomyositis, juvenile dermatomyositis with extensive calcification. So basically just remember that calcification occurs as a metabolic abnormality also. So I don't know what the main process was going on here. This is just a massive lake of calcium. And I can't really say why it developed, but obviously whenever you see calcinosis cutis, you need to ask yourself what's going on. Make sure they don't have calciphylaxis, which obviously is a serious condition that can be fatal when you get calcification of blood vessels and thrombotic vasculopathy. Ask yourself if the patient's got any metabolic connective tissue disease or something else going on here when you see calcium. But this is a nice example of what calcium looks like. It's this purplish, fine kind of granular material. And then you also can get, whoops, something's going on here. Back, there we go. And then you can get these areas that actually can undergo ossification in some areas. So if you get anytime you get massive calcification, you can get secondary bone formation. And probably some of these little areas here are osteoid that's forming within the calcium. So that's calcinosis cutis. Again, just kind of a general reaction pattern. That's a sign of usually some kind of underlying abnormality. Okay, this is also a metabolic disorder, and it's a different situation. So we have a low magnification, a subepidermal blister, and notice that it's got virtually no inflammation. And notice the part of the body it's on. There are no hair follicles here. There's a markedly thickened cornified layer, so it's probably near volar skin. So whenever you see a subepidermal blister with minimal inflammation on volar skin, you should instantly think of one of the porphyrias. And so the porphyria disorders are also metabolic diseases or associated with abnormalities in the heme biosynthesis pathway. You see the nice festooning here, which is helpful. And that actually is seen more commonly in porphyria than it is in some of the other cell poor blistering disorders that can involve acral sites, such as epidermolysis bullosa, either the simplex or the dominant dystrophic or recessive dystrophic types. Those usually give you more kind of scar without festooning. And there's one other finding here that's helpful in distinguishing between porphyria and one of the epidermolysis bullosa conditions. That's the presence of so-called caterpillar bodies, which are dyskeratotic keratinocytes in the roof of the blister overlying the subepidermal blister. And then we'll look at that base of this, and you'll also see the reason that there's festooning, and that's because the blood vessels, the capillaries and the small blood vessels in the dermis, have a markedly thickened PAS positive basal membrane zone around them. So that basically makes those papillary dermis, this dermal papillae, more they're stronger. They can't collapse down. They actually then stay up there, and they're almost like they're forming these little, papillae, and they don't actually then flatten out. And so you commonly see festooning like this in Porphyria and Porphyria tarda. Now, it's very difficult. In fact, I wouldn't even make an attempt to tell the difference between the types of porphyria just based on the morphology. So if this could be hepatoerythropoietic porphyria or any of those, they can look pretty much the same. EPP often doesn't give you any blistering, but it gives you that markedly thickened basal membrane material around the blood vessels. You see lots of that in that condition, but they all pretty much look similar. The main thing you need to know is that what the heme biosynthesis pathway enzymes are that can be associated with this, and the disease, this conditions that can be associated with PCT, like hemochromatosis and HIV infection can be associated with that, and hepatitis. So just make sure you're aware of the various metabolic conditions can be associated with it. One other thing would be pseudo PCT that can be associated with certain medications. That also looks identical to this. And if you do immunofluorescence of this, it can be positive for multiple immunoreactants. Usually they're thick rims of material around those blood vessels. It can be anything from IgG, AM, and C3 to just one immunoreactant to none. It can be all negative. And then you can also see the similar pattern, diffuse coarse ribbons of deposition at the dermatodermal junction, but they can be negative in PCT. So if it's positive, it's helpful. If it's negative, it doesn't really exclude the diagnosis. Okay, another example, and notice the pattern here is quite different. We've got a diffuse involvement here, diffuse dermatitis with involvement of the papillary dermis extending all the way down near certainly the base of the reticular dermis. And we've got both histiocytes here as well as lymphocytes and maybe even some other cells in here. So notice it's diffuse with histiocytes and perhaps even some palisated granulomatous inflammation. When we see that pattern, you see the so-called layer cake pattern of inflammation here. I want you to instantly think about Necrobiosis lipoidica. We've talked about palisated granulomatous inflammation before, and in the center of the palisade of NLD, it's basically degenerated collagen, and you obviously in GA it's mucin, and in rheumatoid nodule it's fibrin, but here we've got degenerated sclerotic collagen that's sitting in the center of this palisaded granulomatous dermatitis. So this is a beautiful example of Necrobiosis lipoidica. One other thing that you see in NLD, and you also see anytime you get sclerotic collagen, are plasma cells. So if you see palisated granulomatous dermatitis with plasma cells, that's a good clue right there that you're dealing with Necrobiosis lipoidica versus any of the other palisated granulomas, which almost never give you plasma cells. So this is a nice example of NLD in this case. And we get lymphocytes and plasma cells in this infiltrate that can be anywhere in the specimen. Superficial, it can be deep, often, in the subcutaneous fat and in the junction between the sclerotic collagen and the fat, you'll see plasma cells. You see that in morphia. So again, it's not specific for NLD, but just it goes along with sclerotic collagen. So just remember that. Okay, our next one is this is an interesting case because it actually was in a funny location, but you can see it's got this diffuse inflammation here. And as we go to higher magnification, we see that there are histiocytes that are forming little rings around something in the center. And we look at this carefully, we see that this is not mucin, it's not degenerated collagen, it's not fibrin, it's got these wispy gossamer strands, these crystals, and these are crystals of gout. And this is an example of cutaneous gout in which there was a secondary granulomatous inflammation surrounding the gout crystals. And we see that not uncommonly. Sometimes we'll just see the gout crystals without much inflammation, but when they've been around for a long time, and I'm not sure what part of the body, so it's kind of an interesting location because usually we'll see gouty tophi present, say, around the ears and things like that. It's often sent in a roux-like chondrodermatitis. Somebody biopsies it and shows the gouty crystals here. This one may have been on the trunk, might, even if you ever biopsy the so-called podagra lesion, the toe, it can look like this. So this may have been a lesion from the toe. And notice the type of biopsy. It's like an excisional biopsy, big, thick, large excision. So they may have thought this was a tumor or something, and they took a deep incisional biopsy, but it doesn't show a tumor, it shows gout. And this is a beautiful example of what these gout crystals look like. Now, if you were to polarize this after it's been fixed in formalin and processed in routine fashion, it's going to be negative. You're not going to see anything with polarization microscopy, because really what we're seeing here are the ghosts of the gout crystals that were present in vivo. If you actually take the tissue and put it in 100% alcohol instead of putting it in formaldehyde, then you can actually see the gouty crystals, and they will polarize. They're birefringent, and if you look at the routine microscopy, they kind of look brown. So gout crystals, even though when we see them clinically that are being transdermally eliminated, look white like chalk. When you look at it when they're fixed in 100% alcohol, they have a brownish color to them. So if we were to do that, we could actually still see the gout crystals, but here we're just seeing the little residual wispy areas that were once gout crystals. And notice that just like any foreign body in the skin, and then the host is recognizing these gout crystals as not, they shouldn't be there in the skin, is forming this granulomatous inflammation secondary as a secondary reaction. Okay, our last one we're going to look at, a little tiny biopsy. And there's a reason for that, because it was actually taken from, I believe, the face. And these were small papules seen in individuals. This is kind of an interesting case because it shows two things. It actually shows an intradermal melanocytic nevus, but then it's got these other structures down here, these yellow, brownish yellow, coiled and curved banana-like structures in the skin. And we talk about these as yellow, brown, golden brown bananas. And that's an example of cutaneous exogenous ochronosis. And you very well, almost take it to the bank. You're going to get a question about this on the board examination. They probably will show you a histologic image like this and expect you to pick up on it. And basically what these are, the elastic fibers that are modified by application of hydroquinone, and they form the homogentic acid that forms a complex with the elastin and leads to these ochronotic elastic fibers that you see here. It actually develops this, it forms a complex. It's a polymer, if you will, and it basically precipitates out in the skin as these golden brown fibers that you see here. And these basically then can form papules. They can become transdermally eliminated, sometimes get some inflammation. Here we see no inflammation at all. And they're present in this melanocytic nevus. Now, I don't know why there's a nevus here and ochronosis. It's possible the patient didn't like the color of the nevus, was trying to get rid of it. Maybe that this is from a dark-skinned patient that had hyperpigmentation and just happened to have a nevus there also, and applied hydroquinone to the area, and then developed secondary ochronosis. So basically, beautiful example of this. Now, you don't get the papules of exogenous ochronosis in patients that have the systemic type of ochronosis. They can get abnormalities of their collagen and their sclera of their eye, the heart valves, their joints, so they get arthritis and whatnot, but they don't get the golden brown elastic fiber changes that we see like this in patients that have been applying hydroquinone. So even though this is it's ochronotic, it's the same kind of chemical pathway, if you will, it doesn't give you don't get those papules in patients that systemic form of ochronosis. So I'd recommend just understanding the pathophysiology of this and maybe knowing a little bit about the chemistry of it. They might ask you something like that on the examination, but they almost certainly going to ask you about the morphology of these fibers. So make sure you know what those look like. Okay, that's it for today. And once again, notice that we didn't cover all the metabolic diseases. So what we're going to do is probably go through the list of all the things that we've done over the last year, maybe give some of these talks on a periodic basis, supplement those with our unknown lectures that we're doing. And then we are in the process of getting a new residency program. And once we get that going, we're going to have a whole setup of educational dermatology lectures and dermatopathology lectures that we're going to record and put online. So we're going to continue adding to our library of educational information. You're obviously welcome to go to that at any time and sign in and learn these topics. Good luck on any of you that are taking the boards coming up. It's in August right now, so I think they're going to be taking place very soon. So hopefully anybody that's a third year, do well on your exam, and look forward to seeing you in lectures in the future.